Before we start today's episode, a word of caution. As part of our discussion today of topical analgesics, we're going to be looking at images of wounds, some of which are graphic and include anatomy like rectal prolapse. So if that is not something that you want to see, I'd recommend that you select a different video. Thank you. All right, we'll get started. All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's episode is on methylene blue as an emerging tool for analgesia. Our guest today is Dr. Carlos Roldan, who is a professor of emergency medicine at McGovern Medical School at UT Health, the University of Texas, and an associate professor of pain medicine at the University of Texas MD Anderson Cancer Center. Dr. Roldan is the author of several recent publications on methylene blue, and he's credited for designing and implementing the use of methylene blue oral rinse in practice at MD Anderson Cancer Center, which has benefited more than 3,000 patients there. Our format for today is going to be a bit of a dialogue, an interview, and then we'll have a few minutes at the end for some questions. So, with that, Carlos, sir, thank you very much for joining us and welcome.
Good morning, everyone. I'm very excited to be here, and I hope I can share something with you that you can find it helpful to help your patients. That's
Perfect.
what we're here for.
All right. So I think we start with the origin story. How did this idea get started, and maybe tell us a little bit about your first patient experience with it?
Yeah, so methylene blue has been used in emergency medicine for multiple things, from injectable for cyanide poisoning, which we did in the emergency department. We also did to inject in several joints. Give you an example, you have a knee trauma. In the emergency department, we inject methylene blue into the joint. If the capsule is intact and there's a laceration, then my residents will take care of that. If the capsule is affected, then we call orthopedics for that. So that will help with that. So we're pretty comfortable using for those things. But methylene blue has been in history for more than 100 years for many, many, many things. You can read about it. The first patient I tried methylene blue for pain was actually a patient with a severe vaginitis for candida. How did I come up with that? When I was a medical student, one of my faculty was a GYN, and he was also a pathologist. And we had a patient with the same description. We had a consult for patient with severe vaginitis, a lot of pain. Apparently nothing was helping with the pain. The patient was screaming in the emergency department, and that was a consult. I never got to see the patient, but when I talked to my attending, I don't know if he was joking. I don't know what he was saying. He said, yeah, how about methylene blue? It's a tissue stabilizer. So he just left that comment right there. But again, I never saw the patient. Back years later, in the emergency department here in the US, I had a patient exactly with the same thing. And the patient is not getting better. They are giving hydromorphone and morphine. She's in tears. Her vagina is so swollen, fissured, red, and painful. So I scratched my head like, what do I do with that one? So I remember that comment, and I said, you know what? I feel very comfortable. I'm not going to hurt this patient, but I told the patient, I'm going to try this, and I don't know, let's try it. And I just got methylene blue out of the vial, and I applied, and I saw that face of relief, and she said, oh my God, thank you so much. I scratched my head again and said, like, for real.
Hmm.
Oh my God, it helped a lot. So that kind of was the first patient I used it for analgesia. Then later on my fellowship as a pain fellow, we had a consult for mucositis, and there was nothing working. I mean, it's just patients getting all the hydromorphone you can get and everything else that everybody uses, and nothing was working. So I went home not feeling very happy because I couldn't figure anything to help this patient. Then I remember this patient back with vaginitis, and I started thinking, okay, what if I just go with a Q-tip and start applying that everywhere in the mouth? And then I started thinking, probably not a good idea. I start gagging the patient. Patient is drooling and miserable. Who's gonna take a Q-tip? So I took that idea, and I went to review the literature in mucositis, and then I started looking at methylene blue. There was nothing around there, but after I showed the vaginitis, I said, maybe there's something that we can do. Finally, in some papers where dilutions were used for photosynthesizer for lichen planus. There was a dilution there, and I'm like, maybe I can try that dilution. So I diluted in normal saline. It was a struggle to have anybody in the department letting me use it. And finally, one of my faculties, because I was a fellow, let me try, and it was an outstanding success. I was like, are you kidding me? The patient rinsed and spit, and it worked really well. This patient had mucositis for 2 weeks, not responding to anything. And after 2 days of using this, patient was back eating and no pain. And so they need to go from there. Then the project started. We did first a retrospective, then a prospective, then another retrospective, and I'll be happy to share the papers later on that. At this point, it has been used for that and other applications, and I'll be happy to share a lot of the information about it.
Sure. All right. So you've described mucositis when we've talked about your bio as sort of a first choice. Can you take us just through the nuts and bolts of how do you use this? When do you start it? What are the side effects you warn people about, et cetera?
So the vast majority of patients that call us are patients that are not responding to conventional options. Put it that way.
Yeah.
I don't think any oncologist or anybody will call it just for patient with a small little sore that is not even bothering. So they will call us when the patients are already in a PCA or they're getting a lot of medication and they're not getting better, or the patients are miserable. So that's when they call us. So when after this took off, now I get a lot of patients, even without pain, especially from radiation oncology. They want me to take the patient even before the mucositis starts. And in those patients, yes, the methylene blue is the first choice because we're just going to start. Many of those patients, they just use methylene blue and they don't use anything else because they're through the process, they just use the methylene blue. But back again, a lot of the patients have already been taking everything, and that's when we take the patients. And as you already know, some of the cases are so severe that there's no way you're going to discontinue anything else. What you can see the progress is once with the pain relief, you can see the gross decrease on the use of narcotics. And the patient is feeling better. Now I'm not taking so much this, and I already stopped this. I want to decrease my fentanyl patch and so forth.
Is there a certain dilution that you're currently using? Because I saw you tried a couple of different dilutions in some of your papers, though it seemed like the 0.1% was the most common that I saw.
So this is excuse me, this is what happened when I started putting the protocol for the prospective trial. I have INH FDA regulations, so they put me under a lot of regulations. And so one of them was you cannot use placebo. So no placebo. You see the prospective trial, no placebo was allowed. The second thing, per FDA, you have to try different dilutions and show which the most diluted concentration will be that is still effective. So that's why I had to come with 3 different dilutions, just to please the research part. And the next thing, they had a concern about the use in the patient with radiation therapy. So they put that restrictions as well. That's why I could not include that in the trial. The concern was that there was the speculation that the radiation therapy could probably cause ionization of the tissue, and that we wouldn't know what the results or what the side effects of that would be. So they didn't allow me to do radiation patients. So that's why all those restrictions. But the dilution that I use the most is 0.05%.
0.05. All right. And
some patients I give more, some patients less, but pretty much 0.05.
Okay. And I saw in your paper you also excluded patients with glucose 6-phosphate dehydrogenase and people on any drug that could potentiate serotonin syndrome.
Pretty much that's also because of the research.
Yeah.
When you have to go under the IRB, and then in the IRB there's a pharmacologist and a chemist and everybody. So everybody put their own things in there. So then they have to put you all of those restrictions, that you have to follow the restrictions they give you under the IRB. However, after after the research is completed, many patients with all of those things, possible precautions, have used it with zero. So far, I mean, I don't know how many thousands of patients have received this. And to this point, we have not heard of any single, not even one, adverse event that we have to be worried about.
Gotcha. So a lot of those things were theoretical initially, and now, I mean, because the argument I've read through all your papers is that, to the best of our knowledge, there is very, very little systemic absorption. So things like serotonin syndrome shouldn't be a relevant concern, but they were just being extra cautious as far as you could tell.
Yeah, so you look at the doses that we use for um, for encephalopathy is 50 milligrams
Mm,
every 6 hours.
mm,
When you look at the dilution, we dilute at 0.01%. And then the concentration in plasma is expected to be 1 in 100 of what you ingest. So to some patients, even joking, I say, hey, if you have suicidal ideation, don't waste your time with this. It's not going to work. You can drink the whole bottle, and this is not going to do anything. It's going to make your urine and feces green,
mm.
but that's not going to hurt. So I use it in patients with renal insufficiency, patients with serotonin medications,
Yeah.
and because the concentration is so diluted and the plasma, this is intended to be topical, but if ingested, then the numbers might go up. But based on the, pharmaco that I review, it's only 1 in 100. So the chances of any real concentration in the plasma is almost zero.
Gotcha. What how much do we know about the mechanism of how this is really working for pain?
So actually there's some good papers, and it has multiple mechanisms. So it's antioxidant, it's anti-inflammatory, but probably the ones that I think are the most helpful, one, there seems to be an effect that is similar to local anesthetics without causing sodium channel blocking. And that's when you see the immediate relief. I have seen patients that even before they spit, they already feel the relief. They're like,
Oh,
I've seen patients smiling and nodding their head like
wow. Hmm.
even before they spit, because it can have some local anesthesia-like effect. So that works immediately
Hmm.
without causing sodium channel blocking. So it doesn't cause numbness. Why is this so important? When you have the patient getting the regular oral rinses with the local anesthetic base, they all complain of numbness. My mouth is so numb that I have no idea what I'm drinking or eating. Many of them, they go desperate to try to get something because they're dehydrated or they're losing weight too quickly, so they're afraid of the gastrostomy tube. So they put the local anything and they try to eat or drink right away, but they say, I have no idea what I drank or I ate because everything is numb. So that's number one. Number two, gag reflex can be blocked by ingesting local anesthetic, so the risk of bronchoaspiration is pretty high. When you do methylene blue, neither of those things happen. There's no numbness and there's no gag reflex changes, so it makes it very safe.
Hmm. All right. I'm
So I forgot, I go back. So
Please.
the other mechanism that seems to be probably very important seems to have some neurolysis. So any terminal nerve endings exposed in those sores, there seems to be some ablating mechanism. So that can be observed as the patients use it several times. Like if, for instance, if the baseline pain is 8, the patient started using it, and then the pain comes back in a few hours. Now it doesn't come back to 8. Now it's come out to 6 or to 5. So there seems to be an accumulative and gradual improvement of the pain levels. And that's probably from neurolysis.
Hmm. I assume, just like anything that's new, you've had a fair number of skeptics about this medication. What are some of the main concerns that you hear about methylene blue, and what are your counter arguments?
Well, I think at least in my patient population, there's no skeptics. Everybody's desperate for something. So they call us again when they're desperate. Patient,
Mm,
we cannot discharge. Patient is very dehydrated, losing weight. Patient started sleeping. So anything you can throw there will work. That works. Please do it. So not so much on the skepticism of this.
mm,
Uh, rather like when I was doing the trial, it was interesting. A few patients, they consented for the study, but when they were assigned to conventional therapy, they quit the study. So they said, you're not gonna give me the methylene blue, I'm out of the study. So in the paper, you see that a few patients just resigned because they want something that works. So we don't see a lot of the skepticism there because everybody's kind of trying to get some relief.
Seems like a reasonable potential for benefit and a very low potential for any sort of harm, if any.
So
Yeah.
far, yes.
So earlier, I was talking to Carlos about how the reason why I found his paper wasn't because of mucositis. It's because sometimes we have patients coming into the hospital with really difficult to control like rectal pain, and that's where I found the rectal prolapse article. I'm curious, other than mucositis, what other ways are you using this?
Yeah, so it's amazing. So after this, the the use of methylene blue has gone up in many ways, not only my practice, but many other people that I find. So it's an amazing topical analgesic. And as a topical analgesic, anywhere that you apply, it works really well. For that kind of indications, I don't even dilute it. So whatever I have, 2%, 1%, if it's the injectable version, I just get the vial and apply directly with a Q-tip. So just to give you ideas of all the things that I use it for, patients with gastrostomy tubes, a lot of them, they complain of severe pain at the insertion point. They have like an ulceration of the skin, right? The insertion point of the gastrostomy. That skin there is an ulceration and it's extremely painful. I've seen patients covered in fentanyl patches to try to get that pain. Tell me, how do you manage that pain? There's no many options. There's no nerve blocks. There's no systemic medication going to help you much. What do you do with that?
Hmm.
So we are applying methylene blue right on that ulceration, and it has worked amazing. So of those patients, I just give them the little vial in a container to take it home, and I barely see them again because they just applied and it works pretty well. It worked in anal fissures. I had a doctor in South America that after I gave a lecture, she met with a pharmacist, and they produced some vaginal ovals. He told me she had a lot of patients with HIV, female patients with HIV, and a lot of sores in the vagina. And she said, there's nothing that we can help these patients with. They're in a lot of narcotics. There's a lot of pain that there's nothing that we can use. We apply lidocaine by last for a few minutes and so forth. After this, they start making some vaginal ovals, and they apply there, and she sent me multiple measures. It works. It works. So it works. So he was very excited. Pretty much any topical pain that you come with, so you can see. Let me see if I can share this screen.
Yeah.
Let me see so those are some of the pictures that let me know if you see it. Can you see it there?
Yeah, we can see it.
Okay. So basically, let me just go to the first one. So that's the one you referred to. This is a palliative doctor in Spain. He read one of my papers. He contacted me by email, and he said, I had this patient, 92, I believe, with a non-surgical rectal prolapse, a lot of pain, nothing helping, poor miserable lady. And then he asked me if I felt comfortable. I said, absolutely. And then he sent me the picture before and after. And in the paper, you can tell how well did it work. So pain went from 8 to 2 after the first application. That they continued doing every 4 to 6 hours. Wow. And at the end, he was off all the painkillers. There's some more pictures of patients that had used it too. He sent me those pictures. This one right here, I actually did it myself. There's a patient here, MD Anderson. She had this chronic ulcer in the scalp, extremely painful, seen by dermatology. They took multiple biopsies. They had tried steroids and all things. They didn't know what to do with this lady. They sent to me for pain. This is 6 months of pain, 6 months. And she's taking gabapentin and max dose and Norco, and she's applying lidocaine. She doesn't know what to do. She cannot sleep. Basically, we did Methylene Blue one time. It was only one application, and the pain totally resolved, completely gone, one application. This one is not the best picture, but you see in the mouth, it's a patient that had radiation therapy, and after that was like 3 or 4 months of complete radiation, she had these remaining little sores under her tongue, and he was also taking methadone, gabapentin. It was a lot of pain, couldn't eat, and I just gave her a Q-tip wet with the Methylene Blue for her to apply herself. And at the first application, she was smiling so happy because the pain was for the first time gone in 6 months. I gave her the rest of the vial, and I scheduled it for a follow-up, but she never came back. So I assumed that she was just fine. You know, patients will come back making noise if they're still not feeling well. Those are other things that this is from the same doctor from Spain. In other applications, this is a patient with rectal cancer, and basically he applied directly into the ulcers. Those are patients that are, you know, with no further treatment and with a lot of pain. So he applied that directly. Same thing with this one. This is another patient from Spain. He just sent me those pictures, and then he feels like he still helps. And in other cases that I've seen, there was one patient with a rectal ulcer. He had rectal cancer, and he was already cancer-free, but he had the residual pain, rectal pain, severe pain. And he got some nerve blocks that didn't work well. He's in methadone, hydromorphone, gabapentin, everything else. And he got a colonoscopy showing a small ulcer from radiation, just a small ulcer into the rectum. So with this patient, we made a calculated, risk, and basically we give a Methylene Blue enema. So we get a fluid enema, we fill it with Methylene Blue, we put it there, and let it sit for a few. And the patient was very happy. He was almost pain-free with that. So pretty much what you can let your imagination go with that and see how many more applications you can find, because I just keep using it over and over, and anything that is topical, I found it to be very low risk. Many advantages of this is that it's extremely cheap. My philosophy, even if I work in a center with high technology, with a lot of resources, a lot of the patients that we see right here, they come from other countries. If you come from another country to MD Anderson, it's because you have money. They're just not going to do it if it's not the case. So we have a lot of technology and a lot of resources, but my philosophy is to try to reach out to people with no resources. So anybody, anywhere, this is no technology. Methylene Blue is available anywhere in the country or in the world. I was in Mexico City, and I had a pediatric patient with mucositis, 6 years old. We just published that recently too. And they asked me, would you do in pediatrics? I said, absolutely, yes. If the kid is able to put in the mouth or gargle, absolutely, yes. So I asked one of the pediatricians, can you find some Methylene Blue for me? And then she came, I had the picture somewhere. She gave me 1 liter of a bottle of 1 liter of Methylene Blue, $3. So I was laughing because I said, with $3, you can almost treat the whole population of Mexico City, like 20-something million people. It's very cheap, and you can get it anywhere. I have patients of mine that, if you go to a compounding pharmacy to mix it, they can charge you a lot of money. But I have patients that told me, I found it on Amazon, and I'm using it, and it works. So this is not a secret, and I'm hoping that it helps a lot of people. To my knowledge, there is at least 11 countries where it's being used already, and that's just per, correspondence that I get from people from many, including Europe, Asia, South America, Central America, and here in the U.S.
Wonderful. All right, we got one question we'll ask you and then we'll let you go. So the question's from Eve, and it's, do you feel it'd be safe near the eyes for something like ocular shingles, or maybe even expanding beyond that? Is there anywhere that you don't, where you prefer to avoid using it?
I don't know how irritant it will be to the cornea, so I wouldn't use it in the eye. And that's just because I don't know. It might be, it's possible, but I just don't know. So I wouldn't try something that I haven't. I know in the skin, the mucosa, any skin, any mucosa, I will have no problem using it. Uh, but in the eye, I don't know.
Absolutely.
I'll probably be more careful with that one.
All
But it
right.
could be irritant. It's a chemical, it can be
Hmm.
irritant. The last thing you want is somebody to file a complaint because you did something nobody else done. So then
Yeah.
probably not. At least if you do it, don't put my name on it. Don't say that I recommend.
All right, Carlos. We are so appreciative of your paper, your work, and you being here with us today to share some of it.
So thank you very much for inviting me. Maybe, hopefully, you invite me in the future. I have more projects that I'm working on. And again, my philosophy is to try to help people with no resources.
Hmm.
That here we are a big pain department. We do a lot of technology and implants and all that, but I try to look for things that help and are low cost that can reach a lot of people throughout the world. So I'll be happy to share any papers that I have right there, but I'm hoping that you can invite me in the future.
Oh, absolutely. I'm going to take you up on that.
Be happy to. Thank you so much.
All right, Carlos. See you later.
You take care. Bye.
Bye.